Two big birthdays as we kick off March. We got Dr. Seuss back in 1904 and John Bon Jovi in 1962. Jan, we are big fans of both Dr. Seuss and Bon Jovi in the Swami Nathan household. If we're talking about Dr. Seuss, I think my personal favorite is the Lorax, although I really have a soft spot for Fox and Socks. Jan, I know that you are a Dr. Seuss fan. What's on your list?
Yeah, I'm a big Dr. Seuss fan. Actually, my dad used to read Dr. Seuss to me and my sister growing up. We had sort of like a compendium of Dr. Seuss books.
Oh, yeah.
So two of my favorites are Wacky Wednesday, which is like where the kid wakes up and everything's wacky. And then when you're looking at the book with all the illustrations, you can pick the things that are like wrong, which I really enjoy. And then the other one was Horton Hatches an Egg, which was before Horton Hears a Who, where the little baby bird's mother, Maisie, like decides to take a vacation to Florida and the elephant has to sit on the egg. And I like that one. Those are my two.
That's a good one. You know, Wacky Wednesday is an interesting one because Seuss wrote all of the words, but it wasn't illustrated. Like he didn't guide the illustration. Someone else illustrated afterwards. So it's this weird amalgam. And if you go back with that in mind, you're like, oh yeah, this is not a Dr. Seuss thing. Like I can see he did not do these pictures, but I do love that one too. My kids loved finding all of the things that were wrong in all of those pictures.
Yes, me too. And that old kids magazine called Highlights, where you would also pick the things that were wrong.
Oh, Jan,
I loved
Highlights.
that thing.
Oh my God, we got to do a deep dive into Highlights. Maybe a whole week on Highlights, because great magazine. My kids still will look through those and they're like, "Can I do the find?" And I'm like, "Dude, that is for a 5-year-old. You better be able to find all those things." But it is great. Keeps everything busy. And then let's go back to John Bon Jovi because I don't know if everybody knows this, but John Bon Jovi is from New Jersey. I know we always highlight people from New Jersey. That is not why we're a big fan. This is a great album. I remember getting this album as a gift at my 10th birthday. It wasn't the first album I owned, but it was one of the first I owned. And because my parents don't actually ever throw anything away, I'm 100% sure I know exactly where that cassette tape is in my parents' house.
Oh, that is classic. A Bon Jovi cassette tape. That is such a throwback. Now, I didn't grow up on the East Coast. I grew up in California, obviously, and I don't love John Bon Jovi probably as much as you do. This is one place where maybe the first place we found that we've
diverted a little bit. A
little bit.
Yeah, I don't know. It's funny. Would I have loved John Bon Jovi if I wasn't from New Jersey? We don't ask these kind of questions. There's no answers to these questions. But I'm going to dig up that tape, Jan. Next time we record, I'm gonna show it. I'm gonna put it on the screen so everyone can see what a cassette tape looks like.
Yes, exactly. We need to educate the young ones about these ancient technologies.
All right, Jay. Well, let's get out of the banter and into a case because I've got a great cardiac arrest case I want to kind of chat about with you and see if you would have managed anything a little bit differently than I did. You ready?
I'm ready.
All right, so we get a pre-notification. There's a 30-something-year-old man coming in cardiac arrest. The patient is coming from a concert, had a collapse, immediate bystander CPR. When EMS arrived, they had a shockable rhythm ×1, but then lost pulses, and now the patient is in PEA or asystole. They're not 100% sure when they're talking to us on the phone. They said they are 2 minutes away. So, Jan, you have 2 minutes. What are you doing in that 2 minutes?
So 2 minutes, we got a young man coming in, cardiac arrest. I'm really crossing my fingers we can get this guy back. You know, young, too good to die, too young to die, I guess I would say. And so I'm going to get stuff ready, assuming that we're going to get this patient back. I'm getting ready for that post-ROSC resuscitation. So I'm going to get RT and airway equipment and, be thinking about what I can possibly find in this case. Get my nurses ready for blood, get an EKG on standby. Now, I may not end up needing any of those things. It depends on how this resus goes, but I'm going to assume I'm going to get this guy back.
You want to have everything kind of lined up for you. 2 minutes is not a long amount of time, but you want to get everything out of in the room. I'm going to have ultrasound. In my shop, we do A-lines. I like to have those intro rests, so I'm going to have an A-line set up ready to go. And this patient literally rolls in 2 minutes after we get the phone call. It was a real 2 minutes. Mechanical CPR is ongoing. There's an LMA in place. There's nothing really additional to the story. There was nobody there that knew the guy who could give any additional information to EMS. He got one epi en route to the hospital. Right now, we've got a saturation of high 90s with that LMA, and the end tidal CO2 is 15. So, we used to go through these like A, B, C. And I know that's not exactly how we do things now, but let's just kind of address those first couple of steps in that order. Jane, you've got an LMA, you've got a good O2 tracing, you've got a good end-tidal CO2 tracing. Are you replacing that LMA? Are you intubating this patient? And just for the listeners out there, of course, Jan works in an academic center, lots of bodies around. So are you going to have someone convert that airway at this point?
So the answer is no, and they're going to want to, but I'm going to say hold. This looks like it's in the right place. Let's focus on the compressions, and I really want to see what rhythm we've got, because you mentioned that it was shockable, but you also mentioned, they're not sure if it's asystole, what is it, PEA, so I really want to do some compressions, and then I want to get a rhythm, because I want to know where I am in my algorithm, because if it's asystole, if it's truly asystole, then, that's a kind of a different pathway, and the ultrasound is going to play a role here too, but I would leave the LMA in. It sounds like it's working, so I would say leave it for right now.
Yeah, I love that. And we have data over the last couple of years initially saying that a supraglottic device is as good as intubating the patient in a cardiac arrest, at least in the first 5, 10, 15, 20 minutes. And we have data saying that, in fact, bag valve mask without a supraglottic device is just fine too. The supraglottic device, definitely easier than having to hold a good seal and do bag valve mask. So great, we've got that in place. Let's not focus on that. We know it takes our attention away from other things. So we're going to leave the LMA. And we're going to move on to some other things. And so one of the questions that came up, young man, cardiac arrest, I don't want to put too many stereotypes on it, but coming from a concert, should we give this guy Narcan? Should we suspect that there could be an opiate involved in this cardiac arrest?
I would. I mean, this is, again, as you mentioned, it is all about the detective work. He's coming from a concert, young man. What is the downside at this point? So I am giving, the 2 milligram IV Narcan. I'm going to give it my best shot. Let's see what happens.
And this is not us saying we should go back to the coma cocktail, right? We're not saying just empirically give thiamine glucose and Narcan, but look at the patient in front of you and consider it. And actually, we have an upcoming segment in a couple of months with Megan Reck diving into a fantastic paper that was published in JAMA about using Narcan in every single patient with cardiac arrest. And they actually showed some improved rates of ROSC, maybe some hint towards improved outcomes. We'll come back to that in a couple of months and really dive deep into that. But in this particular case, we felt the same way you did. There's really no downside. It's not like we're on a shortage of Narcan. It's not like it's a super expensive drug. So we went ahead and, dosing wise, who knows what the right dose is? I think we ended up giving 4 milligrams as a single dose, but I think 2 milligrams would have been fine too. We're talking about IV, not intranasal, but we gave a big slug of Narcan. And it didn't have any effect. We were all hoping that would be the fix. All of a sudden, this guy would come back, sit up, and kind of start pulling stuff out. But no, nothing really happened. But when we got to that first rhythm check, we looked at the monitor, and it was a flat line. But we had an ultrasound in place, and the person running the ultrasound said, this is not flat. This is VFib. There is some quivering motion going on in that left ventricle. So Jan, monitor says nothing. Ultrasound says ventricular fibrillation. Are you shocking this person?
Absolutely. This is one, again, I am looking for anything to try to treat this 30-year-old patient. If it's asystole, then there's just not much for me to do. If you're telling me that there's fine VFib there, I'm saying let's do it. Now, you told me at the beginning, the EMS, when they got there, they had a shockable rhythm. So this makes some sense to me. I'm shocking.
Yeah, I think that's exactly what we were thinking as well. We already had a very low threshold that we were going to apply a shock. And then we see that ultrasound, we're definitely going for it. And we again have a little bit of data here. There's a great article from Gaspari and Annals just from a couple of months ago showing that about 5% of cardiac arrest patients have occult ventricular fibrillation, meaning that they look flat on the monitor, but when you look with ultrasound, you see that quivering motion in the left ventricle. That's an opportunity for us to be able to do something. So electricity here, that's what we wanted to do as well. But let me just make this a little bit more complicated. Let's say that you look with ultrasound and you really don't see much, but you're not getting a great window. It looks flat on the monitor. Would you just shock the flat line? Is there a reason we should? And Jan, I know what all of the TV shows say. They all do it. And then we all make fun of them for doing it. But would you do it in this case?
It's a good question. And if I worked at a place that didn't have an ultrasound, then you're also in the same scenario, which is you've got this young patient, looks like flatline. Is there a chance that there's microscopic, VFib activity happening?
Sure.
All the algorithms would tell you not to shock an asystolic rhythm. I mean, that's what we're all doing. And what's the downside? The downside is you're giving, I don't know if there is a downside. I guess that's where I get stuck. The downside is you're shocking a asystolic rhythm. It's a 30-year-old. You want to try everything you can. I don't know if there's much of a downside. I don't know. It's a short transport time. I might give it a try. I'm not sure what I would do if I didn't have an ultrasound. You gave me the ultrasound piece, so I'm definitely grabbing onto it.
Sure.
If I back up and really think about the flatline, am I shocking flatlines in general? No. I mean, I don't want to give anyone the idea that that's part of an algorithm. But you're also telling me that this is a 30-year-old, just came from a concert, very short downtime, had a shockable rhythm. I would consider it. I can't say for sure whether I'd push the button or not, but I'd consider it. That's all. I don't know.
Special circumstances, right? I mean, we have to take the patient in front of us into account and not just follow those protocols blindly. So I think I feel the same way. This patient had a shockable rhythm recently, short downtime, immediate CPR. I would have a low threshold to apply a shock even if I didn't see activity on the ultrasound, or especially if I didn't get a good ultrasound window. Yeah. And if I had any question about it at all, if I'm like, I see a little twitch on that line, that would be enough for me. I would hit them with juice. And I don't think, Jan, that it would be, I'm going to continue to do it over and over again. But at least once I would give 200, or if your machine goes up to 360, I would give one maximal effort at defibrillation and then kind of say, okay, flat is flat, or ultrasound with no activity is no activity, but I might give it one shot, especially if I wasn't quite sure. So in this case, we clearly saw what looked like ventricular fibrillation on the ultrasound. We hit him with 200 joules, and it looked like he came back because the end tidal CO2 jumped from that 10 to 15 up to 30. We put a finger on the pulse. He clearly had a pulse, and we're like, oh, we've got him back. Now, there was no return of neurologic function, but there was a clear return of spontaneous circulation. And when we looked at the monitor and looked at the rhythm, it was a very wide, complex, I wouldn't quite say a sine wave, Jan, but it was pretty close. We have no lab data back at this point. Would you empirically give calcium, though?
Yes. I would. Again, back to the what is the downside. When you say sine wave, I think of hyper-K. Now, I didn't hear anything about a fistula or any kind of dialysis port sticking out here. I mean, you're always looking for those clues while you're resuscitating, right? You're looking for clues of a dialysis patient. You're looking for some midline sternotomy scar. I mean, is there any medical history that I can pick up on here? And I didn't hear anything like that, but a sine wave makes me think of hyper-K. Again, what is the downside of a push of calcium? It can sometimes act a little bit like a pressor as well. So let's just give it.
Yeah, and I don't want people to come away from this thinking that we're just going to willy-nilly give a bunch of medications to undifferentiated cardiac arrest. This is a particular scenario. So I don't give calcium to most arrest patients. But like you said, if they have a fistula, I'm probably going to give some calcium. And if they have a wide complex, I'm definitely giving calcium in those circumstances. So we went ahead and gave 3 amps of calcium gluconate to this patient. And as we're pushing it, we see it narrow a little bit, which makes us feel good. We're like, okay, calcium was the right thing to do. And we also get a call from the lab about some of the blood that we actually did send on this patient. So we give that calcium gluconate. We see it narrow. We get a phone call from the lab and they tell us that the patient's K is over 8. That's why they called, right? They called for the lab result that's giving them the big red arrows. And they're like, we got to call a doctor for this. He also had a creatinine of 3.5. And a little bit later, because this doesn't come back right away, but a little bit later, maybe about 20, 30 minutes later, we found out that his CK was over 25,000. And so we're thinking young guy, rhabdo, renal failure, hyperkalemia calls the arrest. So we've kind of gone through all that we can do at that point. We've given the calcium. We've sort of semi-stabilized the patient. The A-line is giving us a pressure of about 80 over 40. We start some norepinephrine to get that a little bit higher. Still no return of neurologic function. The EKG doesn't show any ischemic changes. We don't think this is a STEMI that we need to send the patient to the lab for. And we've got the ICU team on the phone. We're going to send them up there. But one of the things that came up is, should I CT this person before they go to the unit? Now, Jan, we have talked about this at length. We don't have to get way into this, but if you had this patient in front of you, average Monday afternoon, so it's kind of busy, but maybe not slammed, would you roll this patient through CT? And what are you scanning before they go up?
Yeah, it's, CT head would be what I would normally do. And the question here is whether to do the pan scan, as you're alluding to. Now, I have a reason. You've just told me that he has a CK over 25,000 with a potassium. So I think I know why he arrested. If he has no signs of any other trauma, like there's no bruises, there's nothing else that I'm worried about, some kind of, the hemoglobin was okay. I'm not worried about a hemorrhage. I'm not worried about those kind of things. I'd probably do a head and that's it. That's me. That's my practice. I probably wouldn't go further. One other reason is because his kidneys are on the line, and so giving a big slug of IV contrast. Is this a case where nephropathy might make a difference for him? His kidneys are just hanging on by a thread. Is that a thing? Is that not a thing? I don't know, but I'd probably just do a head. That's me.
Yeah, that's what I would have done too. But in this case, I just asked the intensivist. I'm like, what do you want? I'm going to go to CT to get ahead. Do you want anything else? And we had a very brief discussion about that contrast issue. And we both kind of agreed, we don't really think that's a real thing. We think it's okay. And honestly, this guy's got a hyperkalemia that caused arrest. I'm probably going to dialyze him anyway. So if you're going to CT now, if you don't mind, just throw on a chest, abdomen, pelvis. My team will come down, take him to CT, and then we'll bring him upstairs. And I'm like, okay, no problem. And I think that cooperation is great. Now, we didn't find anything on the chest, abdomen, pelvis. Not a huge shocker, Jan. Like you said, I have a reason for this arrest, but it might have been something in the back of the intensivist's mind. They might have tried to send the patient back down to CT, which is a lot of work for them. So having that brief conversation about all this stuff seemed to make sense. He got the head. We didn't really find anything on any of the CTs. He went upstairs, got a couple of runs of dialysis, and then on day 2 started waking up, had some return of neurologic function. I wouldn't say completely intact. Even though this was a relatively short downtime, immediate bystander CPR, there was definitely a little bit of cognitive slowing. There were a lot of memory issues, and we're still kind of early in where this patient is going. So we're only a couple of weeks after this happened, and the patient is recovering. They're still in hospital because, they had to fix the rhabdo and take care of a bunch of other things. But the patient did have some return of neurologic function, doesn't need a trach, doesn't need a peg, and then we'll just have to see long-term what happens. But this just brought up so many different issues in cardiac arrest management that we have talked about over the last couple of years, Jen, but maybe not all together.
Yeah, I mean, this is the art of resuscitation, and we all learn the ACLS algorithms, which, if this, then that. But, when you really get good at this and you do this for a long time, there are these subtler points and specific cases and scenarios, like you mentioned, that are worth talking about. I love that we finally got to the H's and the T's. I mean, we finally got to the hyperkalemia, and once you get into PEA, then you have a whole, door open up to you about possibilities. And so I would have been thinking through all those things, and wow, I mean, that sounds like a great save. Even if he's got some memory issues, neuro recovery takes a long time. So, hopefully the prognosis is still quite good.
That's what I'm hoping too. And just I want to hit with 4 take-home points before we move on to the rest of the week. One was about the airway. If you have a supraglottic device in place, it has a good oxygen saturation, good end-tidal CO2, you can leave it. And when things stabilize, you can convert that to a tube. And that's exactly what we did. We intubated this patient before they went to CT, but up till that point, we managed everything with a supraglottic device. Number 2 is occult ventricular fibrillation. The fact that up to 5% of cardiac arrests could be occult VFib just kind of underscores the need to be good at ultrasound intra-arrest to look for that ventricular fibrillation. Or, Jan, if you're not sure and you shock the flatline, no one's really going to blame you for it. Number 3 is about Narcan. We will get deeper into this, but Narcan really may play a place in undifferentiated cardiac arrest cases. But definitely if you get a feeling, a sense that maybe an opiate is at play, go ahead and give a slug of Narcan. I know we talked in the ILCOR segment last year about how maybe calcium isn't as useful in hyperkalemia with ECG changes, but we're all still doing it. If the patient has significant ECG changes, you think it's because of hyperkalemia, go ahead and give the calcium, although empiric calcium, there's really no evidence for. So be a little bit selective where you're applying that calcium. And Jan, with that, we can kind of transition to the rest of the week. We've got some great stuff. We've got a risk management segment with Mike Weinstock and Josh Russell. We've got a short piece from Mel about hands-only CPR. And then Amol is back in the cardiology corner. We got lots to dive into. Before we get to any of that though, Jan, let's do a couple of papers from last month's EMA.